Welcome to our lecture on the cardiovascular system. Let's divide the different contents into the blood, the heart, and the blood vessels. Let's start with the blood. The blood has three general functions for transportation, regulation, and protection. Transportation of oxygen, heat, and waste products to its destinations, regulates pH, the body temperature, and influences fluid contents of the different cells in the body. The blood also serves as a protection. There is clot formation whenever there is an injury in an injured blood vessel to prevent excessive blood loss, and protection from infectious agents in foreign bodies as it works with immunology. Here are the different physical characteristics of blood. It's denser and viscous than water. Temperature is 38, has a pH of 7.35 and 7.45. Bright red blood signifies that it is saturated with oxygen, and a dark red blood is unsaturated with oxygen. The blood contributes to 20% of the extracellular fluid of the body, and the total blood volume for males is 5 to 6 liters and 4 to 5 liters in females. Here are the different ways to acquire blood. First is through venipuncture, which is acquiring blood through the veins, like this in the picture. Finger or heel prick, acquiring blood through the use of lancet. Here is a heel prick and a finger prick. And arterial puncture, acquiring blood through the arteries. Here you could see that the one collecting blood feels for the radial pulse and collects blood through the radial pulse. Here are the different blood components. Whole blood and other fluid and tissues of the body. Whole blood has blood plasma and formed elements. Blood plasma is 55% and the formed elements constitutes 45%. Blood plasma has water, proteins, and other solutes. Formed elements includes the different cells in the blood, including your platelets, white blood cells, and your red blood cells. Your platelets or thrombocytes, white blood cells also called as your leukocytes, and your red blood cells, erythrocytes. And your white blood cells here has different types: neutrophils, lymphocytes, monocytes, eosinophils, and basophils, which we will discuss in a while. Here are the different cells: leukocyte, RBCs, the ones in red, and the smaller ones would be your platelets. Here you could see a sample wherein blood has been centrifuged. You could see the plasma, Buffy coat, and erythrocytes. 55% of the total blood would be plasma. Buffy coat less than 1%, where you could find your leukocytes and platelets. And the hematocrit or erythrocytes, 45% of the total blood. Here's the normal blood count for hematocrit. Less than the normal hematocrit. When the hematocrit is depressed, we call that condition anemia. And polycythemia, wherein there is elevated hematocrit percentage. Hematopoiesis refers to the process of blood cell development. Initially, it starts at the yolk sac in the embryo, then later in the liver of the embryo, and then the last trimester, 7th, 8th, and 9th month age of gestation, the hematopoiesis happens in the bone marrow. You could find red bone marrow in the axial skeleton, pectoral and pelvic girdle, proximal epiphysis of the humerus and femur. Here you could see the pluripotent stem cell where all cells come from, and the pluripotent stem cell differentiates into a myeloid stem cell or a lymphoid stem cell. Myeloid stem cell and lymphoid stem cell are the different cells wherein the different specific cells in the body come from. Worthy to note that lymphocytes are the only cells that divide after leaving the bone marrow. Let's start discussing our RBC, red blood cells, or your erythrocytes. It's biconcave disc. You can see here that it's concave here, and on the other side, it's also concave. It lacks nucleus and other organelles like your mitochondria. It contains hemoglobin, synthesized before loss of the nucleus. Normal amount 5.4 million per microliter blood for males and 4.8 for females. The RBC is specialized for oxygen transport. One hemoglobin can bind to 4 oxygen molecules and transports 23% of total carbon dioxide to the lungs. RBC regulates blood flow and blood pressure also, wherein if there is vasodilation or increase in the diameter of the blood vessel, there is a release of nitric oxide from hemoglobin. RBC also serves as a buffer through your carbonic anhydrase enzyme. It allows your carbon dioxide to be transported as bicarbonate. You can see here that through your carbonic anhydrase enzyme and with your carbon dioxide and water, it can allows carbon dioxide to be transported as bicarbonate. This allows the blood to serve as a buffer through your RBC. Here is the RBC life cycle. The average RBC lifespan is 120 days. Here you could see that there is erythropoiesis in the red bone marrow for RBC. And the RBC circulates for about 120 days in the body. And when the RBC dies and is phagocytosed, no, the globin and heme would be recycled. Globin as an amino acid for reuse it for protein synthesis. The iron would also be used and absorbed for the making again for erythropoiesis of RBC. And then bilirubin will be converted to from unconjugated bilirubin to conjugated bilirubin by your liver. Unconjugated is lipid soluble that is needed to be converted to conjugated bilirubin, because conjugated bilirubin is water soluble, needed so that it could be disposed through the urine or through feces. Proceeding to your white blood cells or your leukocytes, it has different types: granulocytes or agranulocytes. Granulocytes because these different cells have granules. Neutrophil, eosinophil, or basophil. Your neutrophils help in phagocytosis or eating of microorganisms. Eosinophils fight against parasitic infection, and your basophil produces inflammatory and allergic reactions. Agranulocytes include your lymphocyte and monocyte. Lymphocyte produces specific immune responses like your B lymphocyte, T lymphocyte, and your natural killer cells. Your monocyte fights off bacteria, viruses, and fungi. Here you could see a microscopic finding or an image that depicts the different cells of the blood. We have here your leukocytes, particularly this is neutrophil and another neutrophil. This is monocyte, a lymphocyte, an eosinophil, and a basophil. The red ones here are your erythrocytes or RBCs. And this one is an example of a platelet. So what are the functions of your white blood cells? The white blood cells function as soldiers of the body for protection. There is leukocytosis when there is more than 10,000 per microliter count. Normal response from stress, including exercise, infection, and trauma. Leukopenia is a decrease in the count of the white blood cells. It can be caused by radiation, shock, or chemotherapy. So functions to ward off invading microbes and their toxins. As protection, as soldiers of the body. Leukocytes and monocytes kills phagocytosis, does not return back to the circulation. While your lymphocytes, either T or B, they return back to circulation. The T cells kills, and your B cell produces antibodies for protection. Here are the different WBC types. Their the high count may indicate the following, and the low count may indicate the following for the specific types of your WBC. Neutrophils for bacterial infection, burns, and stress and inflammation. Lymphocytes for viral infections, leukemias, and infectious mononucleosis. Monocytes, still viral or even fungal infection, tuberculosis, some leukemias and other chronic diseases. Eosinophils for allergic reactions, parasitic infections, and autoimmune diseases. And your basophils also for allergic reactions, leukemias, cancers, including your hypothyroidism. Let's proceed to your thrombocytes or your platelets. The platelets are from the megakaryoblast. The normal value is 150 to 400,000 per microliter. It is irregularly shaped and nucleated and promotes blood clotting with a lifespan of 5 to 9 days. So when there is a damage in the blood vessel, RBCs attach so as to promote blood clotting to decrease blood loss. Hemostasis is a sequence of responses that stops bleeding. The sequence of hemostasis includes vascular spasm, platelet plug formation, and there will be blood clotting. When there is an injury, vascular spasm will occur, and then there would be platelet plug formation. And then because of the different coagulation cascade that happens through the different factors, intrinsic, extrinsic factors, there would be a formation of the thrombin, okay, for the decrease in blood loss. Vasoconstriction happens, and then there would be platelet activation. Platelet adhesion happens when platelet stick to parts of damaged blood vessel. Platelet activation happens when platelet is release reaction through your ADP or adenosine diphosphate, functions in aggregation, and thromboxane A2 and serotonin, which act as vasoconstrictors. And then there will be platelet aggregation. ADP makes the area more sticky and recruits more platelets, forming a platelet plug. So here you could see when there is a damage, okay, when there's damage, the platelets are activated, they change in shape, okay, they release chemicals and messages that this area is damaged, thus attracting more cells, more platelets at the for a particular injured area, thus making a platelet plug. For the coagulation cascade, it's kind of toxic for your level, but that there are different factors that needs to be activated because the stimulus to start this cascading of the factors that will be activated is from the damaged surface or the trauma. Okay. Eventually, there will be thrombin formation for the making of the platelet plug. Okay. And then there would be activating of the fibrinogen to fibrin, which is needed to dissolve that clot. Here are the different components of hemostasis. There should be vasoconstriction, then platelet activation through your von Willebrand factor and fibrinogen, which results eventually to a platelet plug. Coagulation cascade, making a thrombin to make fibrin and establishing the blood clot. Okay. Once there is blood clot, okay, plasmin is needed for fibrinolysis and clot degradation. When the body does not need anymore the blood clot, Okay, because it has already established the different vessels and has repaired the damage. Plasmin is needed here. Fibrin, no, establishes the uh, platelet plug for the blood clot, and plasmin is needed for fibrinolysis or lyses the fibrin formation and clot degradation when it's not needed anymore. Let's proceed to the different blood groups and blood types. This is needed because some patients in the hospital might have loss of blood because of certain conditions or blood loss from an injury or open wound, thus needing blood transfusion. And not all blood would be suitable to be donated to a recipient. That's why we need to study about the different blood groups. The major blood groups that we use would be your ABO and RH blood groups. Here are different minor blood groups that we could use usually for hemolytic reactions for blood transfusion. So ABO blood group and RH blood group. ABO, RH would be positive or negative. So let's discuss. The ABO blood type, okay, has A, B, AB, and O blood types. They are categorized according to the antigens that are found in the red blood cell. You could see here the different circles. These are your A antigens found in the red blood cell. And in the plasma of the A type A blood has anti-B, antibodies for B. Okay, that's the reason why the blood types compatible for an emergency for A would be blood types A and O. For blood type B, you have here the square or the diamond shaped B antigen. Okay, this represents the antigens. Okay, but this is not the actual. Okay, this is just shape to represent the B antigen and A antigens. And in the B blood type, in the plasma of B, you can find anti-A antibodies, antibodies for A. That's the reason why for blood type B, you can only give blood type B and O to the patient for transfusion. For blood type AB, there are A and B antigens found in the RBC. There are no antibodies found in the plasma. That's why your type AB is the universal recipient because we could give A, B, AB, and type O blood types because your blood type AB has no antibodies in the plasma. For blood type O, you could see there is no antigen found in the RBC. Okay? If you would notice, blood types A, B, and AB, and including O, we can donate O. Okay? Because in the RBC, it has no antigen. So that means O is your universal donor. Donor, we could give O to all blood types. AB, universal recipient, because we AB, we could give the different blood types for type AB. AB, AB, and O. This is for the RH blood typing. Okay. As compared to your ABO blood groups, RH blood group does not immediately produce antibodies, referring to your D antigen. RH negative patients should be transfused or exposed to RHD before producing an antibody. So we have an RH positive with a D antigen and Rh negative without. This is just a nice to know with an Rh positive father and an Rh negative mother, and with a baby that is positive, Rh negative mother with a Rh positive baby. The Rh positive baby, this one, the blood cells enters the body mother's bloodstream, positive. The invading Rh positive blood cells cause the production of Rh antibodies. So, because of the production of the Rh antibodies of the mother, Rh antibodies remain in the mother's bloodstream. So when there is another pregnancy, okay, not the first one, another pregnancy, the Rh antibodies produced here, okay, that remain in the mother's bloodstream will attack the Rh positive baby's blood cells, causing the Rh disease. So this is an hemolytic disease of the newborn when there is an Rh positive father and an Rh negative mother. Let's proceed to blood typing. We need to be able to identify the type of blood of the donor and the recipient. So again, in type A, the donor has type A, for example. And when there is a type A recipient, give the blood type A also with an anti-B, right? Type A recipient, type A blood will have antibodies B or anti-B antibodies. Since there will be no binding, okay, this one is for like a triangle and this one is for circle, okay, the antibody and then the antigen, there would be no clumping seen. So there would be a successful blood type match. We can give A to another type A recipient. We can give type A blood donor to a type A recipient. How about there is a type A blood donor and a type B recipient. So you can see here the circle, the antigens, and then type B recipient has anti-A antibodies. So there would be binding between the antigen, the circle, and the antibody. Thus, because of the binding, it results to agglutination, antibody antigen binding. So, since there is agglutination, clumping would be seen in the sample. Okay? Hemolysis occurs and there would be unsuccessful blood type match. In blood typing, we would be using different sera and it is color coordinated. Blue for anti-A, yellow for anti-B, and white for anti-AB. So here's what we do. We get blood samples, okay? And then we do pricking, and then we have the samples, and then in each sample, we put anti-A serum and then anti-B serum to another one, okay? And there would be a control, which is an untreated blood type. If the result is there is only agglutination in anti-A serum, then that blood type is A. When there is agglutination in only B, okay, then that is type B. For anti-A and anti-B agglutination, then that's AB. If we put anti-A serum here and anti-B serum here, but still no agglutination, then that is blood type O. Okay, so this is blood type testing. And here you could see the RH, no? RH blood typing through anti-D, antigen D. If there is clumping, then that is positive. If there is no clumping for the anti-D, then that is RH negative. Okay. So again, clotting for anti-A, the blue one. Then anti-B for the yellow. Okay. Clumping here, agglutination. Then A positive, B positive, AB positive, O because there's no clumping, and it's negative because there's no clumping for anti-D. This is for blood typing. Now for individuals who are for blood transfusion because they have little or decreased blood volume, and because of a condition or because of trauma, here are the different processes before blood transfusion would be given or done. There should be identification of the correct blood type and acquisition of the blood and cross-matching before we could proceed with blood transfusion so that the blood that we would give to the donor from the recipient is safe for the donor. Because again, if it is not compatible, if it's not a successful match, then it can just cause more harm for the patient. Okay, there's another image. So blood type A has surface antigen A and it has anti-B antibodies. Blood type B, surface antigen B, has anti-A antibodies in plasma. Blood type AB, okay, A and B, AB has surface antigens A and B. It has no antibodies in the plasma. And in type O, no antigen. That's why we could donate type O. And it has anti-A and anti-B antibodies. Again, once there is RBC surface antigens and with the opposing antibodies, and when they attach to another, okay, this one, the triangle, is locks with the specific antibody with the antigen, then there would be agglutination and hemolysis, which we do not want for a patient to receive uh, incompatible blood because there's a process now, blood typing and cross-matching, to be able to secure that the blood that we could donate to the patient is safe. So here's a summary of the donor blood types that we could give to the recipient blood type. So here you could see complete for AB positive as a universal recipient. And O negative in particular is the universal donor. We could give to all blood types. But what happens in reality is we really give for type A patients type A blood, and type B patient type B blood also, type AB, and type O blood. So for cross-matching, we have now the blood of the patient and the blood of the donor. So type A blood of the donor plus the mixing of the anti-B and anti-B antibody of type A recipient. Okay, if there is no binding, then there is a successful blood type match. But if we give a type A blood donor, a type A blood donor to antibody of a type B recipient, then there is binding, then clumping is seen, then hemolysis occurs, then there is an unsuccessful blood type match. We do not proceed with the blood transfusion. Let's proceed to the heart. Anatomy of the heart. Dimensions: 12 centimeters long, 9 centimeters wide, and 6 centimeters thick. Larger foramis and the heart lies in the mediastinum. This is anterior, this is posterior. You could see here the heart in between and is like hugged by the lungs. Here's your heart. is the base, apex of the heart. Base of the heart would be here. The apex of the heart, this one, is formed by the tip of the left ventricle, and the direction is anterior, inferior, and towards the left. Here, the base is formed by the left mostly and the right atria. Right and left atria. Here you could see the covering of the heart. We have fibrous and a serous pericardium. Your serous has a serous parietal and a serous visceral pericardium. Here, the outermost, you can see the fibrous pericardium. And the blue ones here would be your parietal, serous parietal, and serous visceral layers. In between the parietal and the visceral layer is your pericardial cavity. The cavity and that cavity in between the parietal and visceral pleura, it contains pericardial fluid which reduces friction between serous pericardium during contraction of the heart in each heartbeat. Here is your epicardium, which is the external layer, has two layers, the visceral, serous pericardium, and the layer of fibroelastic tissue and adipose tissue, and contains vessels that supply the myocardium. Again, this is your pericardium. This is your myocardium, the main muscle of the heart. It's the middle layer and made up of cardiac muscles. It pumps the heart and is organized into bundles that swirls diagonally. And you have your endocardium, the innermost layer, a thin layer of endothelium, which provides smooth lining to the heart chambers and covers the valves of the heart. So you have a pericardium, myocardium, the main muscle, smooth cell of the heart, and then the endocardium. We have different chambers of the heart or the rooms of the heart. Right atrium, right ventricle, left atrium, and then the left ventricle. This is a posterior view. Posterior view wherein you could see already the pulmonary veins, the four pulmonary veins of the left atrium. Superior and inferior vena cava. This is your right atrium. Fossa ovalis is a remnant of the foramen ovale, which is an opening in the fetal life, an opening between the right atrium and the left atrium. The ligamentum arteriosum is a remnant of the ductus arteriosus. In the embryo, when the baby is not yet delivered, when the fetus is still inside the mother's womb, there is a connection between the aorta and the pulmonary artery. So here you can see the right atrium, right ventricle, left atrium, left ventricle. This is the tricuspid valve with the three cusps, with the three chordae tendineae and the papillary muscles. The mitral valve with the two papillary muscles with the chordae tendineae, which stabilizes the position of your bicuspid or mitral. Here is your pulmonary valve. Your pulmonary valve here, excuse me, your pulmonary valve looks like semilunar or half crescent moons, okay? That's why your pulmonary valve and your aortic valve are your semilunar valves. Your tricuspid and mitral valves are your atrioventricular valves because your tricuspid and your mitral valves are located in between the atria and the ventricles. Okay. Your right atrium receives the oxygenated blood from the body via the superior vena cava, inferior vena cava, and the coronary sinus. Superior vena cava, inferior vena cava, and coronary sinus, which drains the entire heart. Then the right ventricle receives the oxygenated blood from the right atrium via the right atrioventricular orifice and sends it to the lungs via the pulmonary trunk. And blood here goes to right atrium to the right ventricle to the pulmonary trunk through your pulmonary valve. And the blood goes back to the heart, which is already oxygenated from the lungs via the four pulmonary veins through your left atrium. It passes through your mitral or bicuspid valve to your left ventricle, which receives oxygenated blood from the left atrium via the left atrioventricular orifice and sends it to the body via the aorta. So this is your aortic valve, ascending and the arch of your aorta. Here is an inferior view of the transverse section showing the differences between the thickness of the ventricular walls. Left ventricle would be thicker wall as compared to the right ventricle because your left ventricle needs to pump more blood with the force so that the blood would be pumped towards the aorta to the systemic circulation as compared to the lesser force needed for the right ventricle to pump blood towards the pulmonary artery towards the lungs. Fibroskeleton of the heart consists of four dense connective tissue rings surrounding the valves, fused with one another and merged with the interventricular septum. The functions include foundation of the heart valves, point of insertion of the cardiac muscle fibers, and act as electrical insulators. This is a superior view. This is anterior. This is posterior, right side, left side. So here you could see the pulmonary trunk, pulmonary valve, the aortic valve for the aorta. This is for the right tricuspid valve, 1, 2, 3, and mitral or your bicuspid valve, only 2. Semilunar valves, pulmonary and aortic valves, atrioventricular valves, tricuspid, and mitral valves. Okay. They prevent backflow from one chamber to another. So the tricuspid valve prevents backflow of blood from the right ventricle to your right atrium. Mitral prevents backflow from the left ventricle to your left atrium. Aortic valve prevents backflow from aorta to the left ventricle. And the pulmonic or your pulmonary valve prevents backflow of blood from the pulmonary trunk to your right ventricle. So here you could see the established closure of the bicuspid valve when open and closed because the valves are attached to the chordae tendineae, which are attached to the papillary muscles. The papillary muscles are relaxed so that when there is, and it makes the bicuspid valve open, okay, from the left atrium to the left ventricle. And once that happens, to prevent the backflow of blood back to the left atrium, the valves need to close. Okay, valves need to close, and the papillary muscles are contracted, which makes the chordae tendineae taut. Again, the flow of blood from the superior inferior vena cava and coronary sinus going to your right atrium through your tricuspid valve to your right ventricle to your pulmonary valve to your pulmonary trunk and pulmonary arteries, and then there would be oxygenation of the blood. Blood returns to the left atrium through your pulmonary veins, two on the right and two on the left, and then blood from the left atrium through your bicuspid valve goes to the left ventricle to your aorta and to the aorta and aortic valve to your aorta and systemic arteries towards the systemic circulation. And blood would be drained again by your superior inferior vena cava coronary sinus back to the right atrium. This is the flow of the blood in each heartbeat. The coronary circulation includes different arteries and veins that supply the heart muscle and the heart structure itself. Okay, through your right and left coronary arteries, which are direct branches of the ascending aorta. Left coronary and right coronary arteries. Left particularly goes to the anterior portion, and the right coronary has branches extending to the posterior portion. And then you have different veins that eventually drain towards the coronary sinus, which drains towards directly to the right atrium. This is the cardiac muscle and the different components. Your desmosomes hold the muscle fibers together, and you have gap junctions which allow action potential to conduct to neighboring cardiac muscle fiber. Remember, we do not control our heart, and action potential needs to be present so that the heart can pump automatically. Please review the cardiac muscle histology with the different lines, discs, and zones. Cardiac physiology, the conduction system. Why our heart beats? Because the heart has autorhythmic fibers. They are self-excitable muscle fibers that generate action potentials that trigger health contraction, acts as pacemaker and sets the rhythm and electrical excitation, and forms the cardiac conduction system, ensuring that the chambers contract in a coordinated manner. Remember, coordinated, because if the heart is not contracting in a coordinated manner, there would be murmurs that would be heard which are not normal, and through the tracings in our electrocardiogram, the tracings would be abnormal. Okay, so the structures involved in the conduction system starts with the SA node, which is the main pacemaker. SA node then spreads to your atrial myocardium, AV node, bundle of His, bundle branches, Purkinje network, and the ventricular myocardium. SA node influencing the AV node or atrioventricular node. Then there would be spread to your atrioventricular bundle of His, then towards the bundle branches towards the right and left, then to your Purkinje fibers. This is the spread of the action potential. Starting SA, A is the last letter, atrial muscle, AV node. V is the last letter. Then going to your bundle of His, then bundle branches and Purkinje fibers. SA node is the natural pacemaker. It starts with the SA node where cardiac excitation begins. Then proceeding to your AV node where action potential slows and allows atria to empty blood into the ventricle. Then to your bundle of His, only site where AP can conduct from the atria to the ventricles. This is the action potential and contraction of your muscle fibers. Okay, there would be depolarization or the contraction of your heart and then repolarization. Refractory period this time is the time interval during which a second action potential cannot be triggered. Okay, so the second action potential or the action potential following the first one can only happen during repolarization phase. You'll see here the different ions, sodium, potassium, calcium, and potassium, okay, in and out from the extracellular to intracellular and vice versa from the myocyte towards outside, okay, during the contraction of your heart. The electrocardiogram is used as a recording of the different electrical signals propagated by the action potentials through the heart. We use different limbs, limb leads, right arm, right leg, and left leg, and different chest leads. These leads will trace and record the electrical signals propagated by the heart action potentials. And in your ECG, there would be formation of this ECG tracing. In the tracing of an ECG, there would be different waves. A P wave, Q wave, QRS, complex, and a T wave. Okay? The P wave is the depolarization of the atria and response to SA node triggering. So the atria will depolarize and contract. Then there would be a PR interval, delay of AV node to allow filling of the ventricles. The QRS complex would signify the depolarization of the ventricles. Okay, the ventricles will contract, triggering main pumping contractions. Then ST segment, this time, beginning of ventricle repolarization or relaxation, and should be flat. And the T wave for ventricular repolarization, complete relaxation of the ventricles. Depolarization, contraction. Repolarization, relaxation. So you could see here the SA, AV, bundle of his, the branches to your Purkinje fibers will act correspondingly, and the ECG tracing would be able to appear as such with the P wave, QRS complex, and the T wave with the contraction of the atria, the ventricles, and relaxation of the ventricles. So here is the cardiac cycle. When you say systole, it's the contraction of the heart. When you say diastole, it's the relaxation part of the heart. In the systole, there is period of isovolumic contraction wherein the AV valves are closed and your semilunar valves are also closed, but there is contraction. There is period of ejection wherein blood now would be pumped, wherein the semilunar valves, the pulmonary and aortic valves are open. So blood is pushed from the ventricles towards the aorta and to the pulmonary artery. Then there would be relaxation, period of isovolumic relaxation wherein the valves again closed. And in diastole passive ventricular filling, the semilunar valves are closed while the AV valves are open, tricuspid and mitral. So in diastole passive ventricular filling, there would be movement of blood from the atria towards the ventricles. Then in active ventricular filling, no, the semilunar valves will now be closed and AV valves still open to allow more blood. Then the cycle continues for in each heartbeat. It seems a busy image for the pressure and volume changes during the cardiac cycle. Okay, so you could see here the aortic pressure changes, the ventricular pressure, atrial pressure, and the ventricular volume. This is an electrocardiogram with the P, QRS complex, and the T wave. And then phonocardiogram wherein we hear the lub and the dub sounds. The lub and the dub sounds are formed or are heard because of the closure of the different valves. So here is the cardiac cycle with a combination of the different pressures with the movement of the blood forming your electrocardiogram. Your cardiac output is influenced by different factors. The volume of the blood ejected from the left ventricle into the aorta or right ventricle into the pulmonary trunk in each minute. Cardiac reserve is the difference between the maximum cardiac output and the cardiac output at rest, usually 4 to 5 times at resting value. So here, your cardiac output, the formula to get your cardiac output is to multiply heart rate to your stroke volume. Your heart rate is the number of beats in a minute, and your stroke volume is the amount of blood being pumped to the systemic circulation, which is influenced with the contractility of the heart, the strength, the preload, and the afterload. Here you can see the different factors affecting heart rate, increase or decrease. The different factors affecting the stroke volume, which is the amount of blood being pumped to the systemic circulation. It is computed as end diastolic volume minus the end systolic volume. Kind of toxic, but in short, the cardiac output is computed as heart rate multiplied to your stroke volume. The heart is regulated in an autonomic regulation pattern. The cardiovascular center in the medulla oblongata, this one, okay, controls both sympathetic and parasympathetic nerves that innervate the heart, the nerves that control the heart. Okay, this is the brainstem of the central nervous system. This is the cerebellum. This is the cerebrum. Midbrain, pons, and the medulla. So the input would come from higher brain centers and from sensory receptors. And then the output of the heart would be increased through sympathetic cardiac accelerator nerves and decreased parasympathetic vagus nerves. Different hormones play a role in increasing heart rate, including epinephrine, norepinephrine, and thyroid hormones. When there are conditions wherein these different hormones are increased, for example, in thyroid storm or in hyperthyroidism, wherein there is increased thyroid hormones, there's also increase in the heart rate. Trapped ions such as sodium and potassium decrease contractility and heart rate. Sodium blocks calcium inflow during action potential, which eventually decreases contractility, and the potassium blocks generation of action potential. Calcium in turn increases contractility force. Remember your coronary arteries, which supply the blood and oxygen to the heart itself. Coronary arteries are direct branches of the ascending aorta. When coronary arteries are having deposition of different fats and lipids, we have coronary artery disease, which can lead to blockage. That means there might be a particular area of the heart that is blocked and obstructed, which it results to decrease or total absence of blood flow, meaning there would be no oxygen and there could be a possibility that there would be chest pain because of ischemia and eventually dying of the tissues of the heart in myocardial infarction. Okay, for the last topic, blood vessel. We have different blood vessels. We have elastic artery, muscular artery, big arteries. A smaller one would be arterioles, which carry oxygenated blood. A continuous capillary, fenestrated capillary, and a small vein would be a venule. Okay, and then we have medium and large veins. Comparing the layers and structures and functions of the blood vessels, okay, here is an artery, here is a vein. We have different layers of the artery and the vein. Let's start with the tunica interna. The tunica interna has an endothelium, a basement membrane, and an internal elastic lamina. The tunica interna is the inner lining of the blood vessel and direct contact with blood. The endothelium is the innermost layer, endothelium, innermost layer and continuous with the endocardium of the heart. It's made up of simple squamous and produces mediators that regulate vascular smooth muscle and reduces surface friction. Your basement membrane, this one, is the physical support of endothelium and anchors endothelium to the connective tissue and guides cells during blood vessel repair. And your tunica interna has an internal elastic lamina. outermost layer facilitate diffusion of substances. Next is your tunica media. Muscular and connective tissue layer. Muscular. Smooth muscle. Mainly smooth muscle with some elastic fibers, most variable of all the tunics. Regulates blood vessel diameter for vasoconstriction and vasodilation. Decrease in the diameter is vasoconstriction, increase in the diameter is vasodilation, and has an external elastic lamina. Internal elastic and external elastic lamina for arteries. Tunica externa, outer covering of the blood vessel, artery, vein, elastic collagen fibers, and helps anchor the vessels to the surrounding tissues, numerous nerves and blood vessels. The vasa vasorum refers to the vessels that supply the blood vessels themselves. Here you could see the arteries and arterioles. You have elastic arteries, which are the largest, middle vessel wall, well-defined elastic laminae and elastic lamellae. Muscular arteries, medium size, but with the thickest vessel wall. And the smaller arteries or your arterioles would be the smallest size and thinnest vessel wall. Here are its functions and the examples of your arteries, elastic, muscular, and arterioles. After the arteries, which carry your oxygenated blood, arteries to your arterioles, no? Blood proceeds to your capillaries, which are the smallest of blood vessels, connects arterial outflow from the venous to the venous return. Arteriole connects the blood to the venous return. There is microcirculation, the flow of blood from the metariole through the capillaries into the postcapillary venue. Function, exchange of substances between the blood and interstitial fluid. So, aka exchange vessels. Usually, the exchange of substances between blood and interstitial fluid happens in your capillaries. Found in increased numbers in areas with high metabolic activity for the exchange. Examples would be muscle, brain, liver, and kidney, but absent in the lining epithelium, cornea, and lens and cartilage. Different types of capillaries. You have continuous, fenestrated, and discontinuous. The continuous capillaries are the most common. Venues are small veins. Serve as a reservoir of blood. Postcapillary venues. Venues initially receive blood from the capillaries. Smallest venues and muscular venues contain 1 or 2 layers of smooth muscle. Now the veins. Venues small. The veins bigger. Arterioles small. Arteries bigger. Veins thicker, tunica interna than arteries. Tunica externa are the thickest layer. They lack internal and external elastic lamina. If you could remember the picture a while ago. Larger lumen than that of the arteries. Factors that move the blood back to the heart into the pumping action of the heart. And lower limb skeletal muscle contraction. Okay. Your veins contains valves, if you could observe. Okay. These valves, thin fold of tunica interna that form flap-like cusps. It prevents backflow of blood when they are closed. Okay, open. Because if your vein valves are not that functional, then it could result to the engorgement of the veins, especially appreciated in the lower legs, which are referred to as your varicose veins. Okay, different veins that are located in the body, vascular, sinus, and anastomotic veins, superficial veins, deep veins, perforating veins, different types of veins. Blood distribution. Blood reservoirs in the veins and venues. Capillary exchange through diffusion and transcytosis. Diffusion is the most important method of capillary exchange. Passes through intercellular clefts or fenestrations, or diffuses through the cells. Diffuses from area of higher concentration to an area of lower concentration. From the blood to the tissues, oxygen and nutrients, tissues towards the blood, carbon dioxide and waste. So uh, these different examples are exchanged through diffusion. Transcytosis, substances in blood plasma become enclosed within tiny pinocytic vesicles. This is important for large lipid-insoluble molecules like your insulin and antibodies. And different factors that play in the hemodynamics of the preload. Inotropy is the strength of the contraction. No? Volume, preload, affecting the stroke volume, which is the volume that is being pumped from the ventricles to the systemic circulation. Stroke volume times your heart rate makes up your cardiac output. Cardiac output multiplied to your systemic vascular resistance makes up your mean arterial pressure or BP. Then for the control, happens in the medulla oblongata vasomotor center. There is a baroreceptor reflex and chemoreceptor reflex, which is the neural regulation of blood flow. Baroreceptor reflex is pressure sensitive, while your chemoreceptor reflex is sensory receptor sensitive to the chemical composition of the blood. Baroreceptor, the stretch, okay? Chemoreceptor, the changes in your oxygen, carbon dioxide, and hydrogen ions. Different hormones, again, play a part in the control of blood flow and the pressure. Renin, angiotensin, aldosterone system, epinephrine and norepinephrine, which increases your BP primarily. Antidiuretic hormone, when it's increased, it prevents urination or decrease in the formation of urine, eventually increasing BP by increasing the volume in the body, and atrial natriuretic peptide. In checking the circulation, we have different arteries with different pulses in the body. Pulse rate, normal is 60 to 100. There is tachycardia when your heart is beating fast or you have increased pulse rate. Bradycardia, decrease pulse, less than 50 beats per minute. Systolic would be the first sound heard in checking the BP through the sphygmomanometer. Diastolic would be the last sound heard, the pressure during relaxation phase. Pulse pressure is the difference between the systolic and diastolic values. Okay, here is a table that corresponds to the systolic and diastolic measurements for normal, elevated, high blood pressure, stage 1 and stage 2. It's considered already an hypertensive crisis when the BP, systolic pressure, the contraction is higher than 180 degrees. Okay, we have different patients because of hypertensive emergencies and urgencies that are rushed to the hospital. And it's really important to be able to categorize your patients accordingly. Now let's proceed to the systemic circulation through the different branches of the aorta. Aorta, again, arises from the left ventricle. No? So blood from the left ventricle passes the aortic valve to the aorta, and your aorta has different branches going to the neck, to the head, towards the upper extremities, towards the abdomen, and towards the lower extremities. Here is a table with the different branches of the ascending aorta. Okay. Your coronary arteries are also branches coming from the aorta. This is ascending aorta. This is the arch of the aorta. The arch of the aorta primarily has three main branches. I want you to remember the mnemonic ABCs. A is arch of the aorta, B is the brachiocephalic artery, C is the left common carotid artery, and S is the left subclavian artery. The right common carotid artery and the right subclavian artery arises from the brachiocephalic artery. Here you could appreciate the aortic valve, semilunar valve, okay? And the branches, the opening of your right coronary artery and left coronary artery, which supply the heart itself with blood and oxygen. Again, arch of the aorta, ABCs, A, B, C, S. Brachiocephalic, left common carotid, left subclavian. Your right common carotid will arise from the brachiocephalic, right common carotid, and the right subclavian also from the brachiocephalic. Okay. So you could see here the different branches going to the neck and towards the head, vertebral, vertebral arteries right and left, and subclavian, axillary, brachial towards the upper extremity, the arm, forearm, and hand. Okay, so you could see here the subclavian towards the right axillary, brachial, right radial, right ulnar arteries, and the arteries of the hand. So this is the shoulder joint, the arm, elbow, forearm, wrist, and the hand. Okay, vertebral will go towards the neck and the head. Okay, that supply the brain itself. Vertebral will meet, form the basilar artery, and you can see here the different branches that make up the circle of Willis. Okay, from the middle cerebral artery, then you will have the anterior communicating artery, then basilar, then towards the posterior part, cerebral arteries, and posterior communicating arteries. So this is the circle of Willis. Here, incorporated would be the different structures, inferior view of the brain and the circle of Willis. If you want to memorize, go ahead. Okay, which are the branches of your external carotid artery? Some, with the mnemonic, some anatomists like freaking out for medical students. Superior thyroid, ascending pharyngeal, lingual, facial, occipital, posterior, auricular, maxillary, and superficial temporal arteries. Again, branches of the external carotid artery. We have here branches of the axillary artery. Okay, first part, second part, third part. First part will have one branch, the superior thoracic artery. The second part will have two branches, thoracoacromial artery and the lateral thoracic artery. And the third part will have three branches, subscapular, anterior, and posterior humeral circumflex arteries. Again, table, if you really want to read and know about the different arteries that branch from the arch of the aorta and towards the upper extremity. Now for the thoracic aorta, meaning it's the part of the aorta that is located at the thorax where it is enclosed in your rib cage. Okay, there are ribs surrounding. So here you could see the arch of the aorta, A, B, C, S. Then the descending aorta or the thoracic aorta. And the thoracic aorta will have different branches for the posterior intercostal arteries, mediastinal arteries, esophageal arteries, your Your trachea would be here, your esophagus would be here, and then this is your diaphragm. Then pericardial arteries and superior phrenic arteries and subcostal arteries. Again, if you want to know the different arteries again, specifically, then after the heart is here, ascending aorta, arch of the aorta, thoracic aorta. Then after the diaphragm, you will have now the abdominal aorta. And your abdominal aorta will have different branches. And if you could observe here, these are the three primary branches of your aorta that are unpaired. Your celiac, which is located at the T12 level, or the 12 thoracic vertebra, your superior mesenteric artery at the first lumbar vertebra, and your inferior mesenteric artery at the third lumbar vertebra. Okay, and it has different branches. Your celiac trunk will supply the your foregut of the abdomen, midgut, and hindgut of the abdomen, which you will discuss in the digestive system. Celiac trunk, the mnemonic for the branches of the celiac trunk is let's go straight home, left gastric, let's go straight splenic artery, home would be your common hepatic artery. Okay, this is your abdominal aorta. Then celiac, superior mesenteric artery will supply your midgut. So you could see here the different portions of your small intestine, jejunum and ileum, and it will have branches for your colon as well, or large intestine. And your inferior mesenteric artery will supply the hindgut, okay, supplying the transverse colon, descending colon, sigmoid colon, and even your rectum. Again, the different branches of your unpaired visceral branches, celiac trunk, its branches, superior mesenteric artery, its branches, and inferior mesenteric artery and its branches. Your abdominal aorta also has arteries that will supply your adrenal glands, your kidneys, and your gonadal artery. For males, you have the testicular. For females, you have the ovarian arteries. Okay. And then you have the arteries that supply the pelvis, the pelvic area, and the lower extremities. So you have the common iliac, external and internal iliac, femoral, popliteal, and then you have your fibular, and then you have your uh, different minute arteries of the leg and the foot. So this is the hip joint, the thigh, the knee, the leg, the ankle, and the foot. And the different branches. Then venous circulation would be responsible for the return of blood from the different portions of the body. It's somehow is the mirror, but not all cases of the parts of the body. Coronary sinus again drains all tissues of the heart. Superior vena cava drain the head, neck, upper limbs, and thorax. Inferior vena cava drain the abdomen, pelvis, and the lower limbs. This is the right atrium with the coronary sinus drainage at the posterior portion, draining the different portions of the heart back to the right atrium itself. Different veins draining the head, the neck, the brain. So you have different veins here and its branches, not branches, but where will it drain the blood to? Towards the from the hand towards the forearm, arm, back to the superior vena cava. So here's the flow. Particularly, you should be able to manage and be able to see here common veins, superficial veins at the antecubital fossa. Remember your right cephalic, more at the lateral, right basilic arteries, and you could have your right accessory cephalic and right median cubital veins for uh, venipuncture to be able to collect blood from these superficial areas. Veins that drain the hand, cephalic, basilic, and the median antebrachial veins, and eventually draining back to the superior vena cava. For the abdomen, so you have here your right external and internal to your common iliac towards the inferior vena cava. And some veins drain directly to your inferior vena cava, not passing through other veins. So here are the different veins draining the foot, leg, thigh, back to the common iliac artery draining to your inferior vena cava. Then you have your hepatic portal circulation. Now blood from the heart to your abdominal aorta to your proper hepatic artery goes to your liver. And then blood from the portions of the stomach, pancreas, and portions of the large intestine drain to your splenic vein. Seen here is your splenic vein. No? So parts of the stomach drain to your splenic vein, part of your pancreas, and portions of the large intestine drain to your splenic vein. No? Tributaries from the small intestine, large portions of the intestine, stomach, and pancreas drain to your superior mesenteric vein. No? So here, the vein, you could see portions draining from the small intestine, jejunum, and ileum, and from portions of the colon draining to your superior mesenteric artery vein, to your liver, and your liver through your hepatic right and left hepatic veins draining to your inferior vena cava back to your heart. So this is the hepatic portal circulation concerning your liver. Of course, you have your pulmonary circulation. Okay, so blood goes to your lungs from the heart through your right ventricle to your pulmonary trunk so that blood would be oxygenated in your lungs through your capillaries here in the alveoli. And blood goes back to the left atrium through the four pulmonary veins, two on the right and two on the left, back to the left atrium, which blood is now oxygenated. In the mother's womb, in the fetal circulation, there are openings. Okay, blood arrives by the umbilical vein, and because of the ductus venosus, which shunts blood from the placenta away towards the semi-functional liver and towards the heart. Okay, so there's an opening here, which is your ductus venosus. And in the heart, there's an opening between the right atrium and the left atrium through the foramen ovale. And there's an opening between the aorta and the pulmonary trunk. Okay? Oxygenated blood from the placenta enters the right atrium and via the inferior vena cava. Okay? Then the foramen ovale allows oxygenated blood goes from the right to the left, and blood from the pulmonary trunk through your ductus arteriosus goes immediately towards the aorta that is pumped towards the systemic circulation of the fetus. So this is the flow. Okay. Blood from the placenta through your umbilical vein carries oxygenated blood, then passes through your ductus venosus from the liver to your inferior vena cava of the baby to the right atrium because there's an opening between the right atrium and the left through your foramen ovale. Blood goes from the right atrium to your left atrium. Part of the blood goes to your right ventricle to the pulmonary trunk, then to the lungs, pulmonary veins, left atrium, to the left ventricle, to the aorta. Okay, since there's a connection between the pulmonary trunk and the aorta through your ductus arteriosus, blood also could flow from the pulmonary trunk directly to the aorta to the systemic circulation of the fetus, and through the umbilical arteries carries blood, the oxygenated blood, back to the placenta. Fetal, open foramen ovale, and ductus arteriosus, here's the flow. And a newborn, there should be a closure of the foramen ovale. There would now be fossa ovalis, and then there would be ductus arteriosus from the open foramen in the newborn, which is your ductus arteriosus, which becomes your ligamentum arteriosum in the uh, after birth. Okay, foramen ovale becomes your fossa ovalis. Your ductus arteriosus becomes your ligamentum arteriosum. Thank you.